they are likely going to pay out. So at like very ego building introduction. So I'll try to keep my head on the screen here and move forward. And the sentiments are completely echoed to you as well, Hish, for being a mentor to so many out there. So without further ado, today we are going to talk about interceptive orthodontics. So, you know, not a new topic, but something I think that really warrants review on a regular basis, because it's so important that we really don't want to miss certain things during recall examinations, because early detection is key to the best prognosis. So timing is everything on this. So although Hish has already given me this beautiful warm intro, just some background on who I am. I grew up here in London, Ontario, and I went to Western for dental school and orthodontics, so completely inbred. And I practiced as a general dentist, which many of you may not know, from 2000 to 2007. And I enjoyed my time as a GP and was just looking for a change. So decided to apply to ortho and was lucky enough to get accepted to Western. And so I was at Western's ortho school from 2007 to 2010 and have been in private practice since 2010. And 2020, I took a break to wash my hands. So interceptive orthodontic treatment, what is that? It's all simple measures that eliminate the developing malocclusion. So what we're going to talk about today is 5 different topics. We're going to touch on each. We won't get into deep details, obviously, having about an hour today together. So the acronym we're going to remember is ACIT. So A standing for ankylosis, C for crossbite, E ectopic eruption, I impacted canines, and T thumb sucking. So if we can make sure that we don't miss, there's of course a bunch of other things that we need to look at when we're, you know, obviously spacing and crowding and premature loss of teeth and that type of thing. And I think we're all really good at that. But these 5 things are things that we cannot miss. And if we determine these things later than they should be determined, it can have negative effects for the patient for the long run. So we want to make sure we're catching them, right, nipping them in the bud. And you guys are the ones that are seeing them on a regular basis, right from the age of 2. So, or 1 now, I guess, right? So let's start by talking about ankylosis. So ankylosis in the mixed dentition. We see an ankylosed primary tooth. Now, what do we do? Well, it depends on so many factors. And I'm just going to see. Sorry. Okay, so we'll look first at the first factor, and that's age of ankylosis. So how much growth is left? So if we look at the diagram on the upper right, what we know is that if a tooth ankyloses at age 5 versus ankylosing at age 15, the effects are very different. So if we remember back to our biology and how things are growing, when a tooth is ankylosed, we view it to be sinking, but it's actually not sinking. The teeth around it are actually growing. So let's look at the diagram on the left. So we'll look at the primary 5 on the lower there. So let's say that ankylosed at age 5. The teeth on either side of it, which you can see are starting to tip in, they're not actually moving. They're growing normally. So the whole bone structure is growing vertically, whereas the tooth that is ankylosed, that middle primary tooth, is not growing at all. So it appears to be sinking. So it's not that the tooth is actually sinking, it's the teeth around it that are growing. So how much growth is left is a very big factor on the long-term prognosis. So if you see a tooth that's kind of submerged at age 16, we're far less worried. However, if you start to see that infraocclusion closer to the age of like 5, 6, 7, we know that those patients have a ton of growth remaining. So you have to make sure that we're treating things appropriately, which we'll get to. So if the age is older, you can see that we're tending to consider extraction of an ankylosed tooth. And when they're older, we're tending to observe them because there's less deleterious effects that can occur. So the next factor we want to look at is the amount of infraocclusion or presence of side effects. So that's, again, depending on the age and the severity of the ankylosis. So what are the side effects that can happen? Well, you can see again on the top left diagram, the extrusion, over-extrusion of the opposing dentition. So if we're starting to see that, we want to, any side effect you start to see, you want to start considering, and you can see under treatment recommended, more severe or early, it warrants extraction or restoration possibly of that tooth. So you might want to consider putting a little composite over top of that primary tooth in order to prevent the side effects. What other side effects do we have? You can see the molars are tipping into the space there. And then we also get the knife-edged ridges. So if we look at the interproximal bone on either side of that impacted or the ankylosed tooth, you can see they're starting to become a little knife-edged. And so then we worry about the long term of the bone in that area. Are we doing the patient a service by leaving that tooth in there? And I'll just come back to that in a moment. And of course, there's chances of food impaction, so greater chance of caries if that happens. And then the last factor is the presence of the succedaneous tooth. So you can see on the right diagram, we have a permanent tooth. On the left diagram, we do not have a permanent tooth. So now this is a misnomer that I think we all forget about. So normally, we want to, if we don't have an adult tooth, you want to save the primary tooth, of course, right? It's going to hold the bone there and allow for a better implant in the future the longer we can hold the primary tooth, which is absolutely true. However, if you have an ankylosed tooth that ankyloses earlier in life, what's happening is the bone is absolutely not growing in that area. So we are actually better off to extract that primary tooth to allow a little bit better bone development without the tooth in place. So this is counterintuitive to what we normally think. We think, well, there's no adult tooth under there. Why would I extract the primary tooth? It's actually to help keep better bone preservation in that area. So now the diagram on the right, we do have that succedaneous tooth, right? So, and the great news is it will eventually come up and it will correct the bone-related issues that arose as it erupts into place. So the only thing we have to control when there's a succedaneous tooth, a permanent tooth ready to come in, we just have to control the side effects of over-extrusion or tipping of the teeth, but we don't have to worry about the bone because the tooth is going to come and it's going to fix those knife edge ridges. So the main thing out of all this is we want to prevent side effects of the developing dentition, and then we have to think, okay, permanent tooth is there, great, I don't need to worry about extracting it. Permanent tooth is not there, I should consider extracting it if it's early in their age, the age. If you just see like at age 16, it seems like slightly infraoccluded, not so worried about it. It's more so when you see early sinking of those teeth, or relatively speaking, sinking of the teeth. Okay, so that is ankylosis. Next we have crossbite. So this is kind of lots of different things going on with crossbites here. So crossbites can be single teeth, multiple teeth, dental, skeletal, unilateral, bilateral, have a shift, don't have a shift. So what are 3 areas that we have to be concerned with, right? Because there's all these different types of crossbites. We want to make sure there's 3 different types we are not missing. One is the ones that are causing perio. We're going to get into each one in a moment in more detail, but just as a summary, the ones that are causing perio, the ones that their cause is a skeletal problem. So it's not a dental concern, it's more a skeletal problem. So a narrow maxilla, for example. And number 3 are the ones that are causing shifts, right? So the question I'll often get from dentists is, you know, when do you want to see a crossbite, right? And the answer is, well, it depends on the type of crossbite and the cause. So then I'll turn it back over to you and say, Is it causing a periodontal problem? No? Okay, great. So we don't need to worry about it for now for that reason. Number 2, is the cause of it a skeletal problem, right? Is it a narrow maxilla? Because that is a time-dependent treatment. And number 3, is it causing a shift? If it's causing a shift, absolutely, we want to treat it immediately. So why do we want to treat crossbites interceptively? There is little possibility of self-correction. Postponing treatment could result in prolonged treatment of greater complexity. It may lead to permanent deviation and asymmetry of the actual mandible. And of course, periodontal concerns such as recession, fremitus, etc. So let's look at anterior versus posterior crossbites. So we're going to look at posterior to start. So we have 3 different types of crossbite: dental crossbites, functional crossbites, and skeletal crossbites, right? So the dental are of least concern if it's just like 2 teeth that are out of place, right, and then crossbite because of crowding or something like that. Not too concerned about treating that early unless it's causing a problem. Is it causing a periodontal issue? Is recession happening? Is there fremitus on the tooth? Then we do want to consider treating it early. Of course, those things can be caused by other reasons as well, but if it's because of the crossbite. Then the next is functional. So this is probably one of the most common thing that we're good at detecting, I'd say. And that is a functional crossbite. So when we have, you'll see the picture on the lower right, that's showing a crossbite on one side. But what the diagram on the left illustrates is, just the drawing diagram. If you look at the bottom, section B, it shows that's when the teeth are not, they haven't shifted yet. So the maxilla is narrow, so the teeth are not able to interdigitate properly. You can see the midlines, the center midlines of the upper and lower are lined up. However, when the patient goes to close together and try to establish an MI, they shift to their left side. So it looks like a unilateral crossbite, but the issue is it's a bilateral problem. The patient tried to close just straight up and then couldn't find like a comfortable spot to rest, so they shifted off to the one side. This is probably one of the most common things that we will see. And a way to tell, like, hey, is this a functional shift or not, is when they're not biting together, when they just open wide and then just get them to rest together, are the midlines on facial, right? Of course, there's crowding and things like that that can shift midlines for other reasons, or they're more class 2 on one side. But generally speaking, do you see a difference between when they haven't closed and when they close all the way? Does that midline shift to the side of the crossbite? And it always has to be to the side of the crossbite, the midline, right? If it is, boom, they've got a functional shift. This is a posterior functional shift. Now, what is the cause of this? The cause is actually a narrow maxilla. But is it the teeth that are out of place, or is it the jaw that is too narrow? It could be either one or a combination. But the point is, we have a shift. We need to fix it. And the earlier, the better to prevent asymmetry development. Okay, and then, oops. There we go. So the next one is skeletal concerns. So here on the lower right, you see a bilateral posterior crossbite and no shift. So we don't have a functional issue, right, from a standpoint of like the jaw shifting around or anything like that. In this particular one, there's no compensations and they need expansion. So now we just have to determine, is it just the teeth that are kind of angled in, or is it the whole jaw that is narrow and we need to expand out the jaw? And if it's just the teeth that are in a bilateral posterior crossbite and there's no perio issues, there's no shifting, then we actually don't have to worry about it. But if there is skeletal concerns that we need to expand out the skeleton, the maxilla, then you need to treat that right away or get it treated, whatever, if you're doing ortho in the office. So, and different options, of course, to treat that. So, and then the final one is the most obscure one. Oops. And that is no crossbites are present and there's no shift, but the dental compensations are masking it. So let's look at that lower right picture again. And let's say we determine this to be a skeletal problem, right? Or let's say that we have, so that's in the previous category. But let's say that it's actually just the teeth that are appearing to be in this crossbite. So the way I'm trying to explain it is the upper jaw is narrow, but the teeth are kind of flared out a little bit. So they've compensated for the narrow jaw. And so now no crossbite is evident. So what you're looking for is, are the teeth more angled, you know, flared out basically, or have more torque? And if they do, that means we still have a skeletal problem, because if we put the teeth back to where they're supposed to be, then our jaw is too narrow, right? So we need to do a skeletal expansion. So these ones are the ones that are kind of hardest to tell, but you'll know because you'll look and you'll be like, I don't see a crossbite, but something seems off. Is it the torque of the teeth? Are they looking flared out? If I was to, in my mind, put them back into the proper position, would we have a crossbite? So those are ones to be extra careful of, because that is a skeletal problem that's masked by dental compensation. Okay, so now let's move on to anterior crossbites. So anterior, same thing. We've got dental, functional, skeletal, easy. So anterior dental crossbites often cause periodontal problems. And I'm sure you guys have all seen this. We see this probably like at least once a month in our practice, I'd say, in your practices. I will see it a lot more commonly. And so this needs correction immediately. I think we all would recognize that. And to know that, yes, we want to fix the perio issue. So they would get referred for, a perio consultation. And sometimes the periodontist will choose to say, okay, no, you know what, you still have enough attached gingival width there, enough minimally attached gingiva. And so you can go ahead and do the correction and we should be fine. Or they might preemptively say, hey, let's add some attached gingiva for you, and then you can go ahead comfortably with the correction. And the main thing is we got to eliminate that crossbite, and it will, at the very least, help to minimize the further recession due to the crossbite, at least. Of course, it can continue for other reasons. Sorry, there's a lag in my computer here. Okay, so then we have our final type of anterior crossbite, which is skeletal. So this is kind of one of our, sorry, I missed functional. So we're gonna go back to functional. So same thing, like we had a functional shift in the posterior, well, we can have a functional shift in the anterior. So the teeth, the patient's upper incisors are lingually positioned a little bit, so they go to bite together and they bite edge to edge on their teeth. And then, of course, that's not a comfortable position, so they slide forward, and that's the picture shown on the second from the left. And so they go into what we call a functional crossbite. So the way to be able to tell this is, if you put them into CR, do they want to prematurely bite on their centrals or upper anterior teeth? And if you're like, yep, they're doing that in CR, and then they will shift into a comfortable MI position, and that's into a crossbite. So again, we want to treat any functional shifts immediately, whether it's anterior or posterior. And then finally, we go back to skeletal. So now this is a skeletal AP position, right? Anterior, posterior. The other one was a transverse deficiency. This is an anterior, posterior deficiency. So you can look at the little girl on the lower right, and you can see that her upper lip is retruded, right? And when she smiles, you can see she's got that maxillary mid-face deficiency. This is often accompanied by minimal incisor display. You know, the kids, they'll smile and you can barely see their teeth. You see an anterior crossbite. These are all indications of moving towards mid-face deficiency or a skeletal AP position problem. So they've got their retruded lip, they've got a crossbite, even when they're in CR, so you've determined it's not a functional shift. This is, if you take anything out of this lecture, this is what I want you to remember. I want you to take a picture of this and just burn it into your brain. Do not miss an anterior skeletal crossbite. The picture of the blue appliance there on the left is a face mask. Many of you, I'm sure, are familiar with it, but for those that aren't, it's basically the reverse of a headgear. So a headgear helps kind of pull everything backwards, right? And the face mask helps to pull things forward. So basically what happens is this gets, the child wears this at home, and I should have put a picture actually with this child wearing it, but you can imagine that the left part of the appliance, it goes on the chin, so that's a little chin cup. It's not holding the chin back or anything, it's just sitting there in a resting position. The right part of the appliance goes on the forehead, and then the child has something removable or bonded in that they can hook elastics onto, and they just hook it to this appliance. So it's just a constant pull of the maxilla forward. We often combine this with a rapid palatal expander as well to help loosen the sutures left to right. And often when there's a mid-face skeletal deficiency in an AP direction, there's often one in a transverse as well. So we often will do, not always, but we will loosen the sutures, we'll get some transverse expansion, and then have the child wear this. It works like a charm. So the biggest benefit is that we can potentially, for these kids, help them to possibly avoid orthognathic surgery, which Dr. Bazadeh will be discussing, I believe, on April 15th. And if not avoid it, which many of them are able to, if not avoid it, at least minimize the chance of needing it. Maybe we can do compensations with just extractions in the future. Or if they do need surgery, at the very least, it'll be less surgery than they would have needed in the beginning. And we have no regret. If it happens and we know we've done everything to help prevent it, then it is what it is at that point. So treatment options just in general, one, we can use the rapid palatal expanders. So the upper left is the different versions of expanders. Number two is the quad helix. It's basically a different type of expander, a little bit more dental expansion, a little less skeletal expansion. So it depends kind of what you need. Number three, just partial braces. Let's say it's just like a couple of teeth that are out of place and you just want to kind of kick them back into place. You can use partial braces. And of course, we can do aligners. A new product with Invisalign is the Invisalign First. So that is aligners for children for the interceptive phase. So now we're going to move on and talk about ectopic eruption. So the first one we'll talk about is first permanent molars for interceptive treatment. So, you know, these teeth, they're on an abnormal pathway. They are locked underneath the primary 5, and so they tend not to erupt or slowly erupt into the wrong position. And these are pretty common. So depending on the population we're looking at, anywhere between, you know, just under 1% to 6% of populations are going to have this. So we're going to see this, and more often than not. And so the earlier we catch it, the better it is. Not that we're going to treat right away, but at least we know we're watching it. As we know, the 6s tend to erupt between the age of 5 and 7.5. And so you just want to keep an eye, right? By 7, 7.5, you're not seeing those 6s. What's going on? Let's take a deeper look at those. Okay, so clinically, what are we looking at? So what I just mentioned, delayed eruption, right? So age 6, okay, they're not there. That's okay, no problem. Age 7, okay, still willing to wait. By age 7.5 or 8, starting to get a little worried. So if I don't have, and now you might take an x-ray and everything looks normal on the x-ray. Totally okay to wait. As we know, there's lots of variability on age of eruption, but it definitely warrants an x-ray by, you know, late 7, early 8 if you're not seeing them. If it's erupting, of course, with a mesial angulation, which is what the picture is detected there, and lack of symmetry. So if you're seeing one side, but you're not seeing the other side, as we know, we want to see the tooth, the contralateral tooth within 6 months of eruption of the first tooth. So you'll make a note at your recall, okay, 1/6 was erupted, I don't see 2/6, no problem, I'm not worried, and then you're seeing them back in 6 to 9 months, and you're like, still don't see 2/6, now point of concern, let's take a look. And then, of course, prematurely mobile teeth are also a concern. So, you know, you'll be checking and seeing like, oh, the 5 is, the primary 5 is mobile. Why is that? That doesn't make sense, right? So another indication of an ectopically erupting first molar. So radiographically, by well, these are often seen on bite wings, right? You're taking those anyways at an early age, and so you'll tend to get an early diagnosis there. And then by age 7, it is recommended that every child have a panoramic at the age of 7. So not by the age of 7. I mean, if you've already taken one for other reasons, that's great. We can kind of use that as our marker. But age 7 is really great because we get to see any major issues that may be developing. Are the canines generally in the right spot? Are all the teeth present? It helps to determine our long-term plan. If there's some congenitally missing teeth, are there any things off path? Is there pathology, of course, any mesiodens or supernumeraries or anything like that? So it's really good general check, low radiation. We do it once at the age of 7. If we don't see any issues, then of course, you know, we're not worried about taking another one for quite a while. So the grading of the ectopic eruption. So if we see something where it's just slightly hooked under, then we're just basically observing it, no problem. Grade 2, okay, so it's like hooked under there. That's not likely going to erupt on its own. Let's look at possibly some treatment options. We'll come to that in a moment. Number 3 is like, we're there. We're less than halfway over the tooth, but we're definitely impacted, so that for sure needs treatment as well. And here where we have when the mesial root of the second primary molar is affected, then we're actually considering extracting at that point the primary molar and doing some treatment. So grade 1, again, we're here, no treatment yet. A lot of these will spontaneously self-correct, and if they will, they'll normally correct by age 7. We'll observe it for 6 months, check again, and if before the age of 8, we're still just observing it, if it does not correct, then we will go ahead and consider some active treatment. Okay, so second one. Now this is, the tooth is actually submerged. You can see it clinically, but it is stuck underneath that primary 5. So this is not able to self-correct, but some really easy treatments that can be done, and which you can try in your office if you wish. And that's just simply putting an orthodontic separator in between those 2 teeth. And don't leave it in there for long, of course. You want to check them, I'd say, every about 10 days. And you should see the picture on the upper right shows you the correction, like an amazing correction in such a short period of time. With kids, these teeth move like they're in Play-Doh, so you'll see a good correction. The chance of not seeing it is quite small. You want to, of course, keep track of these people, though. You don't want to leave these elastics in there. You want to make sure if they come back and they don't know if it's fallen out or not, you have to make sure that it's not wedged down in there. Likely not. It probably did fall out if you see the correction. You might want to take an x-ray of it if you're unsure as to where the elastic is to make sure it's not wedged. And make sure the elastics you use are radio opaque, so they are detectable, which I think most of them are like that. Next step, if that's not working, is to just slide a gold ligature underneath. So you will need some freezing for this, and you basically it's like a gold piece of wire, you slide it in from the buccal or the lingual, it doesn't matter, there's no science to this. You're just going underneath the contact, feeding it through, twisting it around the occlusal of the contact, and then just tightening it. So just a twist, 2 or 3 twists. The patient will feel like, yeah, I feel something. They feel pressure. They won't feel any pain at that moment, but you will definitely let them know that they will be sore. Even with the orthodontic separator, there will be some soreness. So some Advil or Tylenol is totally fine. And then next we have grade 3 or 4. So that's like a pretty significant now intrusion into the 5. And interestingly, you know, sometimes these guys self-correct. So, you know, they're in the literature, they don't, right? But you just see so many variations clinically. So it's okay to give it a little bit of waiting time if you're unsure. And, but technically when you're seeing something that's in the grade 3, grade 4 category, then you want to consider extraction of the primary tooth. And then we have to determine whether we're going to maintain the space or not. So this is where we kind of have to know the long-term game plan of the overall orthodontic plan. So we have to know our endpoint, because are we maintaining and saving the space? Are we recreating the space, or are we letting the space close in? It's going to depend on what the future overall orthodontic plan is going to be. So often it's super clear, super easy. You're like, yeah, they're class 1, they've got mild crowding, we're just losing this. So then it's a matter of determining, you know, we may want to space regain in that scenario. But again, so many different variables that would help us decide whether we want to regain that space or not.
Tanisha, I have a question for you here.
Sure.
Ali asks, how do you charge for this? And this is the previous slide where you put the spacers in.
Oh, for this spacer, like, it would be something like, I don't even know, to be honest. I'm going to say like $150, something like that. It would be something very minimal. Okay, and fourth, we're going to go to I of ACIT, and that is impacted canines. So this is, again, just a timing thing that I really want everyone to take home with them. So impacted canines, they occur in 1 to 2% of the population. So again, it's like, it's a small number, but it's a large number given all the patients that we have in our existing practices. So maxillary canines are actually the second most impacted tooth in the human dentition. Wisdom teeth are, of course, number 1. And it's actually more common in females than it is in males. And that's probably, you know, multiple factors, but one of them just having smaller arches. So what are the causes of impaction? There you go. There's like tons, and this isn't even the full list, like so many different reasons. So the reason is actually less important. It's more, what are we going to do? Because we see it, because we can't get rid of the reason, unless of course it's something like a supernumerary. If it is ankylosis, I shouldn't say the reason isn't important. It is, but if we're just seeing it in a normal scenario where we know it's not associated with a syndrome, or it's not pathology or supernumerary, if it's one of those things, we're obviously going to take care of that, and hopefully that will actually eliminate the impaction. Is it an odontoma there? Two interesting points of note are the upper 2 left reasons, which is the peg lateral and the congenitally missing lateral. Is there's a theory that maxillary, or the upper canines, use the laterals as their guide to kind of go into place. So if you have a peg lateral or a missing lateral, the canine is like confused, like, where do I go? So that's why they tend to just start mesially, kind of stay on this mesial migration eruption path, and they lose their way basically, so because they don't have the regular size lateral to help guide it. So if you have somebody with a peg lateral or a congenitally missing lateral, make a note to keep an eye on that erupting canine, because they're the ones that often get kind of messed up on both. They've got a peg lateral or a congenitally missing and an impacted canine. So that's like a double whammy. We don't want to, we want to do everything in our power to help prevent the canine from becoming impacted. So early diagnosis of the impacted canine, sorry, that's not well positioned there, but basically by the age of 8 to 10, if we can diagnose that it's on its way to being impacted, we can really help to reduce the ramifications of this. So what do? We're doing a clinical exam. Every time somebody comes in and they're around that age 8, 9, 10 zone, we are doing a visual inspection, right? Do we see signs? So the lower left shows us a little canine bulge there. The middle is also showing a canine bulge. And the palatal there on the lower right photo, you're seeing a bit of a bulge that's starting to form around the, I guess we'll call it the 2-3 on the palatal. So being aware to see where that canine is. Inclination of the lateral. So this is very interesting. So you see in this picture, the 1-2, the lateral, upper right lateral, it has a significant distal incline. That is often, not always, but often an indicator of a palatal impaction of the canine. The opposite, so when you have a mesial angulation, it's often an indicator of a buccal impaction. So again, just taking an x-ray, making sure, okay, no, canine looks okay. That's just a crowded tooth, no biggie. But if we're seeing the canine is off as well, we know it's likely a good way of determining whether it's palatal or buccal. Oh, so then the third one was palpation of the alveolar process. So first we were just visually looking at it. Now we're actually palpating it, and buccal and lingual. By age 8, we want to feel a little something. And if you're not, it's okay. Again, we're waiting, but we're happy if we feel it. So it was funny when I then was pulling up photos for this and I put in palpation of canine, this is what came up. So I had to share that with everyone because I thought that was cute. So we know how to palpate a canine area, so we didn't need a photo of that. We also want to look again at symmetry of eruption, just like we did for the 6s. And the primary canine should have some mobility by the age of 10. So this is one we can just burn into our brain. If the primary canine has no mobility at the age of 10 and you don't have any PANs recent, I'd take a PAN. Just check that canine because we can really help to avoid issues. So there we go. So radiographic assessment is warranted. Generally, age 7, right? We want to take a PAN if we're seeing asymmetric eruption, asymmetric palpation, a displacement during palpation. So we feel around forward and we're like, oh, I feel a bulge there, but it's closer to the lateral or it's closer to the fore. Unpalpable at age 10 or a lack of mobility of the primary canine. Late eruption of the lateral incisor also can be an indicator, and a significant angulation of the lateral, which we just talked about. Okay, so now we have a PAN. Now what? Okay, so here is an overall good table that shows kind of the thought process. So the first thing we're looking at is, actually, let me just describe them first. So overlap of the incisor. So the red is the canine and the grayed out tooth is the lateral. So you can see here there's no overlap. We're looking at the upper left. There's no overlap. So pretty good prognosis. As soon as it is overlapping a half or less, then it's average prognosis. If it's complete overlap, poor prognosis. So it gives you an idea to, as an indicator to the patient. We're going to get into a little bit more detail on that. The vertical height of the canine, if it's halfway up the root or less, then to the CEJ, from the root to the CEJ, good prognosis. If it's half to greater than half, then average prognosis. And if it's the full length of the tooth, then poor prognosis. Angulation, 0 to 15 degrees, not bad. Average, 16 to 30, greater than 30 degrees, poor prognosis. Position to the apex. So now we're looking at the apex of the canine tooth. If it's, so it says above the canine position, meaning if the apex of the canine is technically where it should be, if we were to straighten the tooth out, good prognosis. And if it's distal to that, above the first premolar, then it's average. And then if it goes even further, second premolar, then of course, poor. Okay, so good prognosis generally if we extract the primary, if we are good prognosis, so we're looking at column 1. Sorry, this is not working. So good prognosis if we're in column 1. So generally, if most of the indicators fall into column 1, we're good. We would go ahead and extract the primary canine. Not just because no horizontal overlap, that's most of them, we want them to be, but you want it to be no horizontal overlap, but they've got a little bit more angulation you like to see, position of the apex is off, the vertical height is off a little bit. So if you're seeing at least one of those indicators, then you can go ahead and say, okay, let's extract the primary canine to help guide it into the right spot. If we're in the middle column, average, then we need to consider all factors, the age of the patient and definitive orthodontic treatment plan. So we may still extract, but we're not 100% sure without knowing our full plan. And then if we're in the poor prognosis, there's much less of a chance of deciding to save that tooth. So we might actually want to maintain the primary tooth. So this is not an all-encompassing, you know, you see the impacted canine, so you're like, okay, let's get rid of that primary tooth. No, we might not be able to save the permanent tooth, so then you want to hold on. So we want to kind of hedge our bets here. If we think we're going to be able to bring it in, we go ahead and extract the primary tooth. If we don't, if we're not sure, then we want to kind of, determine if it might be wiser for the patient to move forward with extraction of the canine and maintaining that for future implant. So lots to think about there. So specifically, we're talking about the overlap. So if the canine is overlapping the lateral by half or more, then extracting the primary canine helped in 64% of the cases. If, however, it was less than half of the lateral root, then 91% actually normalized. So if we're less, you can comfortably say, if it looks in a decent position and it's just overlapping the lateral just a little bit, a really good idea to consider extraction of the primary tooth. And that was a study by Erickson and Curall, which is kind of one of those landmark studies that we still follow. So they did another study and basically found that 78% of palatably erupting ectopic canines, they normalized within 12 months after extraction of the deciduous canine. So again, study had 46 people in it, but definitely showing some improvement there. And the last stat that I'll throw at you right now is that study showed that a 40% reduction in permanent canine impaction by extracting when the permanent canine tooth is off path. Again, we got to pick properly, but if we're picking properly, it does seem to be helping. So management of the impacted canines. So we can do no treatment, just kind of watch it and check for changes. Extract the primary canine, which we just discussed in detail here. So that's our mixed dentition kind of interceptive treatment, which we're focused on. But of course, you know, we might try these things and it still doesn't come down. So then we have to consider surgical exposure and orthodontic alignment, possibly surgical repositioning or extraction of the permanent canine for a future implant. Okay, so now last topic, thumb sucking. So here we go. 70 to 90% of children will suck their thumb at non-nutritive sucking at some point in their life. So I thought that number was super interesting because it was actually much higher than I even thought. And interestingly as well, digit sucking is far more common than pacifier use. I think a lot of people know now not to give their children pacifiers, what I will argue is to say, if they are sucking their thumb, it's better to let them suck on a pacifier because you can take the pacifier away and it's much harder to control a digit habit. A little side note, which many of you might know, is if they are using a pacifier, a way to help get them off the pacifier rather than just a cold, like, take it away, is to start cutting it. So cut off the tip of it, then cut off another millimeter a week later, another millimeter, and that sometimes tends to work. So why is thumb sucking a concern? Well, only 15%, 14.6 to be precise, have no malocclusion. The vast majority, 48%, will get an anterior open bite. A small percentage will get just a posterior crossbite, and then 30% will get a combination of both. So our biggest indicator is really that anterior open bite, but definitely a cause of the posterior crossbite as well. So we want to wait to treat if they're under the age of 4. They're kind of not ready at that point to let it go. And some are, so you can definitely ask if the child is ready. That's like a really important part of getting rid of the habit. If the child does not want to stop, then it's best to work on getting the child on board prior to doing this to not traumatize them. And even in older children, if the behavior is not frequent or does not interfere with the dentition, cause social stigma or harm their self-esteem, therapy is not necessary in that point. So it's okay. If it's not causing any problems emotionally or physically to them, no big deal. so no need to treat it. If they're under the age of 4, we can still wait a little bit. We got some playing time. That being said, I've seen some crazy malocclusions developing even by this age. So I have put one in, even in someone who's under 4. They were like 3.5. And it was the smallest little crib ever, but man, did it work. He had an open bite of, gosh, I want to say, I don't remember exactly, but it was something like 7 or 8 millimeters. And you can imagine in a little 3-year-old, that is a huge open bite, massive overjet. And it improved like tenfold by the time it was in there for even just like 4 months. So you see the improvements actually really fast. So first you just start, if you're like, okay, yes, we want to treat it. What do we do? So we are going to first just use positive reinforcement. We're not going to jump into using appliances. We're, give them like set up a treat on, if you don't do it for 7 days, then do this, and any type of positive reinforcement, not negative reinforcement though, and or punishment. And then if that's not working, but they still want to try, then we jump into doing treatment with an appliance, both super effective. Cribs or bluegrass are 2 common ones. I personally use the crib and like to say that I see a lot of success with it. General recommendations are to leave it in place for 10 months. You will often, the habit will be gone the day you put it in. So it's pretty awesome most of the time. So like in the high 90%, the habit is just gone. The open bite, you'll tend to see, if this is the only cause of the open bite, it will close in less than 4 months. You'll see it come together. And you take before and after pictures and show those parents. They love to see those changes. And then habit stops immediately, of course. You see the overbite. If you have overbite at the end of treatment, that tends to be a very stable improvement. So that's pretty awesome. Okay, so there we have it. Ankylosis, ACIT, ankylosis, crossbite, ectopic eruption, impacted canines, thumb sucking. These are the things we want to catch at the right time, pretty much as early as you can detect them. We're doing our patients a great service by preventing other issues, the other things of crowding in class 2 and all that type of thing is all good. But the one thing, these are the 5 things that we do not want to miss, because it does have a long-term repercussion to the patient if we miss those. So I'll just end off with a couple of quick studies, because I'm an orthodontist, I want to show you some braces. And so here we have a 32-year-old male. A big difference in today's orthodontics and the past is we have a lot more options available to us. And, everyone's got different theories and philosophies, just like general dentistry of, extract or not to extract. That is the question. So here we, have that option of a lot more non-extracting treatment. And we've chosen, back in the day, this would have always been what we call 4 fours on the floor. So we would have taken 4 premolars out, no question. But now, we've got some other ideas, and that is to expand the arches, not a skeletal expansion, of course, but just a dental expansion. You can see like the teeth in the buccal segments are tipped in. And so we got the braces on, and this shows in sequence approximately 3 months apart for each photo. So starting on the upper left, going towards the right, you can see by 7 months, so like the crowding is like pretty much gone. And then at 16 months, prepared for deband. The lower, same concept. Look at that, those canines there, the one completely blocked out. And basically at 7 months, you're looking like at pretty decent alignment, 10, 13, and 16 months done. So you have a beautiful result there. So I'm just gonna go back and kind of point out the big advantage. So of course we saved 4 teeth, so that's fantastic. Look at his upper center photo where he's his smiling photo front on. And you see right at the corner of the lips, you see some dark areas, right? So that's the buccal corridors. So we call those wide buccal corridors, which is just a little less aesthetic, right? Because you can see like hallways, right? That's the corridors, showing kind of a black appearance. And then at the end, you don't have those corridors anymore because we've widened out that smile. And of course, it doesn't change the face per se from a standpoint of left to right, but we have gotten a nice aesthetic result, just a wider smile. Here's another example, class 1, severe crowding, deep bite, all the cuspids are blocked out. Again, back in the day, we would have always said, take out for bicuspids. Nothing wrong with that treatment plan. However, we would often choose, oh, sorry, going back there, looking at the difference in just in 2.5 months. Look at that difference there, like just insane as to what can be done in non-extraction cases. Again, not all cases can do this. We often do need to extract, but many options to save the teeth. And then there we are, his final treatment. No extractions, no RPE, no surgery, good to go, super happy. And so here we go. Sometimes I feel like I have the worst job in the world. The toilet paper says, yeah, right. But the toothbrush says, at least people think you're the cure to COVID. I can't hear you laughing. I hope you're laughing. And I'll open it up now to any questions.
Thank you so much, Manisha. We have a ton of questions, and they all came kind of in at once. So, okay. The first two questions come from Noha Balbaki. Okay. Her first question is: when do you make the decision of approaching the crowding case with CD4 sequential exo?
Sequential exos have very strong parameters. So you want to have, for sure, a class 1 dentition, severe crowding of greater than 10 millimeters in each arch. And we also have to take into account, of course, the vertical, the depth of the bite, if they're more a vertical case, then less chance of wanting to maintain everything, a greater chance of wanting to move down the sequential extraction pathway. And of course, transverse deficiencies, like the cases we showed here, they had 10 millimeters of crowding in each arch, but we chose non-extraction. So it really is case dependent as to, we just have to look at all of those parameters. And then on top of that is growth, right? So and the bottom line is I'm leery to do sequential extractions because of the vast majority now that I feel like can be treated non-extraction. So I want to give them the benefit of the doubt with growth and being able to, of course, maintain those 5s or 4s or premolars for the long run for the aesthetic benefit. I myself, for example, had teeth extracted when I was treated at age 12, and today I wish I had my premolars.
Her next question is, do we do bilateral primary canine extractions if we have unilateral impaction?
No, just the unilateral, the one that is causing the issue. The bilateral applies more to the lower arch. So if you've prematurely lost a primary canine because the lateral erupted, that is a time to consider extraction on the contralateral side. You don't want to lose the midline. There is varying studies on this topic. Some will say do it, some will say don't. I fall into the concept of maintaining midlines. So if your midlines are generally pretty good, you can keep an eye on it. If you're starting to lose your midline towards the side that lost its primary canine, then you want to consider extraction of the canine on the other side. Or consider even early treatment and regaining that midline if it's quite significant. If I have a midline that's significantly off, I do want to regain it, but we don't have to worry about unilateral extractions in the upper arch. It's more so a concern on the lower.
Thank you. Noor asks, what if we notice class 3 in toddlers? When is the earliest to consider treatment?
Right. So the best time is once the 6s erupt. So the upper 6s is what we ideally need for good anchorage. You can treat earlier, but it's a challenge because, they are wearing an external appliance. You need some good cooperation. So as long as it's before the age of 8, so as soon as the 6s erupt or before the age of 8 is your best time to get the maximum result. You don't have to worry about treating it at age 3 or 4 or 5. It can be done, definitely. You've got those kids that are super compliant and they're excited because they've seen siblings in treatment. So you can do it, but it's not necessary. It's totally fine to wait to before the age of 8. So the conundrum comes when you have sixes that have not erupted and you have a child that's 8, right? So I would like to just go ahead and start without the sixes then and use a removable appliance to get anchorage from the whole entire arch and start treatment. You definitely don't want to be waiting past 8, and if you can do sooner, better. So between ages of 6 and 8.
Gotcha, thank you. Nazia asks, for the retained primary second molar, do you ideally extract or put occlusal composites, or I can even make an addition and say crown as well?
For the ankylosed one?
Correct, for a retained primary second molar.
Yes. Sorry, could you just repeat the question so I got it exactly right?
Sure. For the retained primary second molar, do you ideally extract, or do you put an occlusal composite?
So it'll depend again on those factors that we discussed. So if there is if there is an adult tooth underneath it, it's fine to just keep it, and you only need to put that occlusal composite on top if you're starting to see side effects. There's no harm with putting it, but you can imagine it is more difficult to keep it clean. So if you're not really seeing any side effects, checking, it depends on how much it is infra-occluded. So if it's just a little bit, not causing really any side effects, continue to observe. As long as you know you're able to see that patient regularly. If you've kind of got somebody that's a little less compliant with coming in, then I'd say, hey, it's important for you to come in because I got to keep watching this. Or if you're really unsure, just go ahead and put on the restoration. I would not extract it unless the parameters are in place to extract it, i.e. like a severe ankylosis, you're getting your side effects and there's no adult tooth underneath it. That's the biggest key. And that's something, again, I get so many calls on this that I'll recommend to have an ankylosed tooth extracted. And the dentist is very hesitant to do it because there's no primary tooth underneath it. But the primary concern is the long-term bone. The long-term bone is far better off with that tooth gone if there's no adult tooth underneath it.
Correct. Noor asks, how do you feel about distal shoes?
I do like them if they're required. So for those of you that maybe don't know what a distal shoe is, it's when you don't have your 6 erupted to act as a space maintainer. So you want to use a primary tooth and kind of maintain the space going backwards, kind of to help this guide the 6 into place. If the parameters are there to use it, like you can get it in the right spot to help guide the 6, absolutely a great idea. Because it's, again, an ounce of prevention is better than a pound of care. So if just by a simple space maintainer, you can guide that 6 into place when needed, far better than just letting it erupt wherever it's going to erupt and then needing to distalize it later. That's a lot more work, right? So better to prevent than treat.
Stephanie asks, when, if ever, do you justify taking a CBCT for assessment of potentially impacted canines?
So it depends on when we're ready to treat, basically. So obviously, if you're seeing any type of pathology or anything like that, and if everything's looking normal, but you're just waiting to actually treat and you know you're going to be doing orthodontic treatment later, then I would do the CBCT closer to the time of the exposure to determine exactly, its exact position and then go from there. I don't see any specific need to do it prior to knowing you actually want to do something to it unless you see pathology.
The next question is from Omar. He asks, how many days would you suggest waiting before seeing the patient back after treating a grade 2 ectopic eruption of FPM?
Grade 2, so where you've placed the separator in, I would say every 10 days I would see them. And either place a new separator if it hasn't straightened, or tighten that golden wire, the golden ligature.
We have Ashfaq that asks 2 questions. His first is, in the event that the primary 5 or E is missing, how effective is the use of a distalizing spring-loaded reverse band and loop space maintainer / distalizer?
Yep, it's totally effective. It's really when it comes to options to regain space, carte blanche. You know, so many different options, and we just base it on, of course, what we're used to, what we like. What you just have to make sure whenever you're moving teeth is that your opposing arch is not in your way, right? So sometimes we'll say, well, it's not working, and it's more because the occlusion is preventing the movement. So you have to have either enough power to overcome that, or know that you've kind of looked at that. Especially when we're doing limited treatment, we want to make sure that the other teeth are not in the way. So definitely a good option.
The second question is, please verify that in the event of extracting the primary 4 or 5 or both, no space maintainer is required if the upper and lower 6s are in full digitation in MI.
Correct. Yes. And I'm going to add to that, that is the recommendation. However, I will always be letting the patient know that I do need to see them regularly, and I want to keep an eye that we're not losing space.
You got it. A couple more questions here from Amr. He asks, how much do you charge for a bluegrass or habit-breaking device?
Around $600 to $850 is the going rate on that.
And then finally from Ross, he asks, how often, if ever, do you utilize myofunctional therapy to your patients to prevent some relapsing of some of these cases?
Right. So myofunctional therapy is, again, one of those kind of pie in the sky topics. I think it does, for 100% has its place, depends on what the actual cause is. Do we have a specific thing like a forward tongue posture? What are we trying? Is there speech issues? And so I do work with some speech therapists and in combined with myofunctional, if we know there's a specific issue that we're trying to address. Unfortunately, the parameters are, again, very unclear on you know, what we should and shouldn't do, or what is, I shouldn't say should and shouldn't do, but what is effective and what is not. So definitely, you know, worth a try if that is our kind of determined to be the cause of the problem.
You got it. A couple more questions.
Sure.
And one is from John Mansour. And I know earlier there was somebody who asked if there's any recommendations of a pediatric dental textbook. John, if you don't mind helping us out here and kind of giving us your favorite on the chat group. But John asks, how often do you need a PA to assess an impacted canine over a panoramic radiograph? How often, and how often does it change your decision to treat or not treat?
I'm going to say very infrequently. So I will say a majority of decisions will be made on a panoramic, but again, we'll move forward. The concern is if I'm unsure on, for example, something that I see. So is the lateral root intact? I want to, if I'm not able to see the outline properly, then I'd like a few more views because obviously if, let's say we have significant crowding, we're thinking of extracting a 4 and yet the lateral is on its way out, then of course we're going to keep the canine, right? Keep the, get the canine in the position of the lateral and not extract the 4 as an example. So if I'm pretty clear on what's going on, I don't need anything additional. I don't think I don't routinely get panoramic or get PAs, but occasionally if I'm unclear. And then of course, before making a final long-term treatment decision, I will request a CBCT.
Awesome. Rawad asks, aside from the compliance, is there ever a contraindication to removing a fixed lingual wire and putting the patient in a removable Essex after ortho treatment?
That's a great question. So the compliance obviously being number 1. Number 2 is if you are doing that, I would have to, there is a chance that if you don't know the pre-existing malocclusion, So if there was severe rotations or severe crowding where, like, let's say like one of the teeth, the laterals or centrals, incisors were blocked out of the arch or severely lingually positioned or severely rotated, they, as we know, retain crazy memory. And so those teeth can shift within a matter of days slightly back towards their original position. If you happen to know pre-orthodontically where they were, it's a super helpful. So if they're like, yeah, you know, or you've got pictures, you're like, yeah, it's pretty much all straight, just a little bit of mild rotations, less of a concern then. If there was significant, then I have a significant concern. I would really highly recommend to keep that on. The thing that can help to prevent it is overcorrection of those issues. So if it was rotated distally, or let's say an easier example is if it was severely lingually positioned, actually I should go back and I'm going to say severe rotation. And so to overcorrect the rotation and then bring it back will help to maintain it. But again, that's not the end all and be all, but it will help. But if you don't know, if you were not the treating practitioner, you don't know these things. So it's best to keep it on. If the patient wants it off, you can definitely do it. I would get them to sign a piece of papers noting that you did recommend that this is the best retention. You do expect some level of relapse. They'll still be okay as long as they are compliant with their retainer, but likely some level of relapse. And patients are happy to sign that if they are really unhappy with their lingual retainer or having difficulty keeping it clean or that type of thing. And then, you know, you might recommend to have it off if they're having a very difficult time cleaning it, then it's okay to recommend it. But there's pluses and minuses. So say, hey, your hygiene's gonna be better, but it's at the expense of probably some minor rotations as long as you're compliant, and significant possibly rotations if you are not compliant.
Thank you for that. So Dr. Mansour did post the book that was recommended, that he recommends. It's pretty straightforward, and it's a pretty generalized study guide. He put the link on the chat group if whoever is interested in that. Liz asks, what is the oldest age of a patient that you would consider using a habit-breaking appliance? Oh,
that's a great question. Honestly, I don't have a limit in my mind. I would put it in anyone. It helps to eliminate the habit almost immediately, really speaking. So you could do it in anyone you wish.
Beautiful. And then Aaliyah asks, to follow up with that, are habit-breaking appliances charged under ortho codes, or is it a different code?
You know what? That's a good question. And I'm pretty sure there is a general code for it as well. But I am not 100% sure on that. So you can just look in the ODA guide under preventive. I believe there is a habit breaking section there, and then these appliances would fall under that. If they're there, you can definitely use them. And the best way to do, though, is just if you've never done it in the past, go ahead and do a predetermination. You can do a separate lab code as well, and just so the patient knows for sure whether it's covered or not.
And Noha asks, if the open bite is the outcome of an airway issue at 4 to 6 years of age, how do you approach the case?
So I would first start by referral to a pediatric ENT and get direction from them, because we have to determine, like, you know, adenoids and tonsils and infections and what's happening. So I would 100% start with a referral there and gain direction from our medical colleagues.
I'm going to take a crack at this one. Amr says, I saw your cases that you put fixed upper and lower retainer. In what cases would you do that? I asked for clarification or a rephrase, but we'll take a crack at it. Okay,
sounds good. So me personally, I put a fixed retainer on all my lower, cases. And so the average person in my office will get a lower fixed retainer that we make right in-house, right chair side. And if you're interested in learning about that and you're in the area, you're welcome to come and see it when we reopen. And then for the upper arch, I added, so that's lower 3 to 3. For the upper arch, I do 2 to 2, generally speaking, and that will be only in cases that have severe rotations, severe vertical discrepancies, buccolingual discrepancies, or significant spacing, a large diastema. The diastemas 100% are getting it. And that could even be just a 1-to-1 if needed. So upper is dependent on the initial occlusion. If it's kind of severe in any plane of space, vertical, transverse, AP, rotation. But for everyone else, I would do just lower only, but they're both getting upper lower Essex. If we've done significant expansion, they will get a Holly retainer. And of course, patient preference always takes precedence over everything. If they say, nope, I don't want any fixed retainers, no problem, then we go ahead with our next best option. And then, but I do, if they're not going with what our recommendation is, then I will get them to sign a consent that it was their choice.
Awesome. And Angela shared with us the codes. Thank you, Angela, for doing that. So for a maxilla, this is a habit-breaking appliance code. For a maxilla, it's 14101. And for a mandible, it's 14102.
Awesome. And don't forget to use, you can use your lab code 99111 as well.
This is a question from me. And yes. I see that Dr. Sumner is on the chat group as well. So this will also apply to him as well. What is your take on not only just clear aligners, but I guess the evolution of, scanning, printing, in orthodontics, and that how do you apply that to your practice, and where do you see the industry going moving forward?
Yeah, awesome. Another great question. All great questions, actually. So currently, I think in the industry, many people, and I speak for ortho and probably applies to general as well, where a lot of us are moving in towards at least we've got the scanners going, right? From an orthodontic standpoint, I think we are moving into completely digital workflow. Myself, as my office is going exactly in that direction. We are scanning, 3D printing, making retainers in-house, and moving into the direction of in-house aligners as well. I think they have an awesome spot in today's market, not in the future market, but in today's market. Everyone needs it cheaper and yesterday, but not in lieu of quality or end result. So I think what we have out there with like SureSmile and ULab and the softwares, and of course Invisalign, there is a lot of opportunity for us to expand our practices. And now I speak to everyone as general practitioners. Case selection is key. Don't be afraid to try some things in-house and start slow and move into that direction, but being really careful with case selection, because I think going in too strong, too fast is what gets us into trouble. And of course, when we're moving all the teeth in the arch, then we can get into trouble fast. So just be careful with that. As long as you're selecting cases well within your comfort zone, amazing opportunity to do your in-house aligners.
Awesome. Thank you so much. Any other questions? I guess we'll leave it open, even if you want to type it in or if you want to just jump in and ask the question to Dr. Jindal. Please feel free to do so. A couple of announcements that I want to make. Once again, we have the one and only Vic Jindal speaking to us tomorrow about current markets, economic outlook, and the recession cycle. That will be at 12 p.m. I did put the link up in the chat group, and I just wanted to make sure that I let everyone know that space will be limited to 300 individuals. So, my recommendation is to come on early. I also want to make a special announcement that we have a star-studded lineup coming up on the week of April 14th. Backed by popular demand, Dr. Azim Sheikh, Kayvon Abazadeh, Stephen Diana, Bian Kwek, Jeff Sumner. Every one of these individuals I'm sure that you've seen in the speaking track, and every one of them is a world-leading expert in their field. So please feel free to tune in. Once again, they start on April 14th.
And I'll just pipe in and just chat about it for those of you that weren't on at the time that I was just talking to a few others on the site about is just recently, I believe as of today, there has been a court ruling by the Ontario courts. So if you guys are all in Ontario, which I assume you are, that they are counting viruses as practice disruption. So potentially full reimbursement for our losses. So
I'm going to ask you a question here, because as soon as I heard the news, I did call my my broker. Now,
okay.
Would you advise us as dentists, Manisha, and just for those who don't know, Vic Jindal is Manisha's brother, and he is a leading expert in anything like this when it comes to any type of insurance. Would you advise every one of us to go ahead and put the application in for work disruption right away, or do you advise that we wait until this the pandemic is over and we're going back to work?
Right. So I speak as a colleague, not as an expert on this, but of course as a vehicle from Vic. We have just this morning done it for me, and so I would advise the same to all of you. We don't know for sure, so please don't take this as 100% this is happening. The insurance companies have not responded to this yet, but the Ontario courts have ruled it. So then the question, our next question would always be, well, what if they oppose it, like the insurance companies? And our thought, speaking with Vic this morning, our thought is that they will not be able to oppose it for too long, because it is the Ontario courts that ruled it. It wasn't anyone else. So I feel like we're in the clear. We don't know for sure, of course. I have no idea how this whole system works, but it's looking super promising. So the reason we recommend to get your application in ASAP is because as the news spreads, of course, just like EI, there's going to be a backlog. So let's all be at the forefront of it.
Awesome. Thank you so much, Manisha. Any other questions? All righty. It looks like we are good to go. I hope you guys all enjoy the rest of your Thursday. We look forward to seeing everybody tomorrow. And please don't hesitate to let us know if you have additional questions or concerns. We'll be compiling this email list, and then after that, we'll be emailing you guys the CE certificates for that. Now, Manisha, some of these individuals have asked for the lecture, if possible. Will you be sharing that with us?
Yes, absolutely. No problem.
Awesome. Perfect. Thank you so much. Okay, everyone, have a great day, and we look forward to seeing everyone tomorrow.
Awesome. Thanks. Bye. Bye. Nice seeing everyone. Take care, guys. Enjoy.